Well, ladies and gentlemen, thank you very much for asking me to give a talk today. I'm going to be controversial as I normally am at this meeting because it's quite good fun. So please accept a lot of what I'm saying is slightly tongue-in-cheek. Obviously, I would much rather be with you today in Cairo, as I have been for 3 previous years. And I obviously miss sort of pressing the flesh and meeting my friends there. And hopefully this time next year will be a good time to be in Cairo. In fact, the last time I was on an aeroplane was at this conference last year. The title of my talk today, rather controversially, is that systematic para-aortic lymphadenectomy is obsolete in gynecological oncology surgery. For those of you who don't know me, I'm head of gynae oncology at the Royal Marsden Hospital in London. We're the #1 HEFSCI rated cancer centre in Europe. I'm one of the medical directors there, and I also work at St George's. And I'm putting down SERG's educational network on my front slide. And I hope people will go to the SERG's website, which is a society I'm very fond of. I don't have any disclosures today, other than the fact that I want you all to come to Svendborg in Denmark for a face-to-face meeting. I think this will probably be the first one that happens after the pandemic. We were going to have a meeting in May in Cork last year. We were one of the first people to put together a virtual meeting. It turned out to be very successful. We're a really social group, and I do hope that you will come and listen to us or come and listen to the great presentations in Svendborg and meet the industry there. I want to start today by looking at the year 1998. And if you can't think back 22, 23 years ago, I'll just remind you of what happened in that year. This was the year that Bill Clinton did not have sexual relations with Monica Lewinsky. And on that theme, it was the year that FDA gave Viagra a license. The Spice Girls told us what they wanted, what they really, really wanted. And it was the year that Google's founded. It's amazing to think that Google's only 22 years old. I'm presenting this on an iMac, and it's amazing to think that an iMac was only launched 22 years ago. Windows 98 was the most popular operating system. And I remember that was the year that I first videoed a laparoscopic para-aortic lymphadenectomy. I used a Betamax video recorder. So, it shows you how times have changed since this year in 1998. I wish I could find that video. I couldn't, but I found one 4 years later. This is it, and you can see it's rather low quality. But you can see we were pretty aggressive in those days. We can see the aorta here with the inferior mesenteric artery, the bifurcation and the IVC. We can see the third lumbar artery. I'm sorry, it's not very good definition, but high definition video didn't exist then. And we were showing these at meetings and trying to show what wonderful surgeons we were. And, it became a bit of look how big mine is sort of thing. These operations can go wrong. And anyone who does para-aortic lymph node dissections on a regular basis will have at least once in their lifetime nicked the inferior vena cava. And everyone will know that that's probably the most stressful thing that happens to them, as blood suddenly wishes up and you rush to control it, and your suction irrigation isn't working all of a sudden, and your gas goes just at the wrong moment, and all those things. So this is a very, very, very stressful situation. This is a functional flow rate CT scan of my left anterior descending coronary artery. It's also known, if you can't remember your medical school days, it's also known as the widow maker. And you can see around a blue area and a red area here, but in September of this year, I had an 80% occlusion in my left anterior descending coronary artery, or widow maker. Well, that's because I'm in my later years, and I admit I was a smoker when I'm younger, and I'm an insulin-dependent diabetic. But imagine a sudden increase in blood pressure while nicking the IVC, and what could have happened to me. Luckily, I've had a stent put in this now, but, you know, this is a stressful procedure if it doesn't go well. And the complications don't just include IVC rupture, but they also include hemorrhage from other sources. You can cause chylosocites, you can have hypergastric nerve injuries, which can affect women's ability to defecate, urinate, and have orgasms. You can have ureteric injuries. The ureter gets very near these things. You need to identify it. And of course, death to the patient. And as I've already articulated, potentially even death to the surgeon. 2021 is different. We have, I'd say, better PET scanning. I think probably say we had PET scanning. I don't think it existed 22 years ago, or it was just coming in. We have much, much better CT scanning. It's quicker to do, multi-slice. We have a T4, 4 Tesla MRI in our institution. I understand 5 Teslas coming in. And we have ICG sentinel lymph node dissection. And here is a large lymph node that was picked up on scan. And you can go after these individual nodes with ICG. It's a much more precise thing without dissecting out the whole anatomy. It's not as fun to do because you don't see the anatomy, but it's much safer for the patient. So let's go through all our different cancers and see which ones we would consider doing a para-aortic, systematic para-aortic lymph node on, and which ones we wouldn't. Well, what about ovary cancer? So this is a randomized control study in 2019, arguably one of the more important randomized control studies in 2019, published in the New England Journal of Medicine. And this study was finished. And it was predominantly from a group in Essen, and I congratulate them on it. It's a fabulous study. What they did is they looked at systematically doing a lymphadenectomy at ovary cancer for high stage ovary cancer versus not doing a systematic lymphadenectomy. And the median overall survival, if they did a lymphadenectomy, was 65.5 months, and the median survival, if they did not do a lymphadenectomy, was 69.2 months. That's quite a non-significant result if you think about it. In fact, the survival was better with no lymphadenectomy. Progression-free survival was identical in both sides. By the way, the overall survival was the same because it wasn't significant. So I don't want you to think that I'm claiming that it was better. However, the complication rates were double in the lymphadenectomy arm compared to the no lymphadenectomy arm. That's the serious complication rates, not the overall complication rates. The Clavien-Dando type 3 complications were double in the lymphadenectomy arm. And the 60-day mortality was 3 times higher in the lymphadenectomy arm. So really now, with this evidence from a randomized control study, grade 1 evidence of a well-controlled trial, really demonstrate that with high stage ovarian cancer, you should not be doing lymphadenectomies. You do not increase the survival, and you significantly increase the mortality and the complications. So what about early stage ovary cancer? Surely we should be doing lymphadenectomies to determine whether or not we give these patients chemotherapy, whether we should upstage them. And this is a paper from my unit. There are a lot of small studies, and this is looking at laparoscopic surgery. You can see I actually did 34 out of these 35 operations in this paper, but the paper was put together by my colleague Des Barton, who doesn't really do this type of work, supervising what was then one of our fellows, Ellie Blockbank, who many of you will know is a consultant now at Barts. But during this paper, she also did a systematic review of other studies looking at upstaging apparently early stage ovarian cancer. Now, you will note that there are not many early stage ovarian cancers to be upstaged. So the numbers in all the series are quite small, but enough to get some feel for it. And we can see that about a quarter of patients with apparent early stage ovarian cancer are upstaged if you do surgical staging, including the pelvic and para-aortic lymph nodes. But if I go back to this paper, because I know this paper well and I know the patients in it, there were 8 patients out of the 35 who were upstaged. Yeah, just under a quarter of them, similar to the other studies. But of those 8 patients, none of them were upstaged for isolated para-aortic lymph nodes. All of them either had a mental involvement, peritoneal involvement, contralateral ovary involvement, or isolated enlarged nodes also seen on scan, which were involved. So not a single patient would have not received chemotherapy when they should have done because of the absence of doing a para-aortic lymph node dissection. And we've already identified that doing a para-aortic lymph node dissection doesn't affect treatment. So in ovary cancer, there's no role for systematic para-aortic lymphadenectomy, not for treatment, not for staging, and certainly not for influencing the role of chemotherapy. Now, I give one concession to this. There are rare cases of germ cell tumours. And these tumours often have large lymph node chains going up into the chest. They're often bulky. But I would argue that the gynae-oncologist is now de-skilled, because I'm going to argue we shouldn't be doing lymphadenectomies for anything else. And really, we should be referring these patients to our urologists who do testicular cancer, because the numbers here are too small. So, not in endometrial cancer, not in ovary cancer. What about endometrial cancer? There is some evidence that high-grade endometrial cancer with deep myometrial invasion has a 25% instance of para-aortic lymph node involvement. I got this from a paper from Kriesman, but it's in all the textbooks. You know, when you train to be a gynae-oncologist, that's the figure. A quarter of patients with high-grade endometrial cancer with deep myometrial invasion will have para-aortic lymph node involvement, and therefore we must do para-aortic lymph nodes. No. But it's why the ESMO-ESGO-ESTRO consensus conference statement said, if a lymphadenectomy is performed, systematic removal of pelvic and para-aortic nodes up to the level of the renal vein should be considered. The problem is it's a consensus. You know, it's confirmation bias amongst people agreeing with each other. It's not based on evidence. The NCCN guidelines, which isn't a sort of an elite group of 35 people saying, I think we should do this, says that lymph node assessment includes evaluation of the nodal basins that drain the uterus and often comprises a pelvic nodal dissection with or without para-aortic nodal dissection. And this continues to be an important aspect of surgical staging in women with uterine confined endometrial cancer, as the procedure provides important prognostic information that may alter treatment decisions. And para-aortic nodal evaluation from the inframesenteric and infrarenal regions may also be utilized for staging in women with high-grade tumors, such as deeply invasive lesions, high-grade histology, and tumors of serous carcinoma, clear cell carcinoma, or carcinosarcoma. Let's think about that. Because only 2% of isolated para-aortic lymph node involvement. So we know from a lot of these studies that although 25% of women do have para-aortic nodes, only 2% of them are isolated para-aortic lymph nodes. And these can probably be tracked using a combination of ICG sentinel lymph nodes, and there are many studies that confirm this now, and imaging. So the only reason to do this, to remove the para-aortic lymph nodes in endometrial cancer, would be if there is a therapeutic role for it. And there is a study that does suggest it. This is a study published in Cancer, which looks at the therapeutic role, looking and analyzing the SEERS database. That's the Surveillance, Epidemiology and End Results database in the States. And it does suggest it, but it's an observational data. And of course, you're more likely to have a para-aortic lymph node dissection in a recognized cancer center. But I'm going to argue there's no therapeutic advantage. The reason being is that there are multiple randomized control trials now, which contain somewhere just under 2,000 patients. And this is the meta-analysis from Jonathan Frost and Joe Morrison, who demonstrated that there was no survival benefit for systematic lymphadenectomy in endometrial cancer. But what there was, and I quote, however, women who underwent lymphadenectomy had a significantly higher risk of surgery-related systemic morbidity and lymphedema/lymphocyst formation than those who did not undergo lymphadenectomy. Relative risk 3.72 and 8.39 respectively. 1,922 participants, high quality evidence. Okay, what about cervical cancer? Well, we know the presence of positive lymph nodes is an indication for chemoradiation, and we would know that the presence of para-aortic nodes would alter a chemoradiotherapy field. So let's do para-aortic lymphadenectomies in these patients. Well, that's been looked at again. Look at the date, 2003, a randomized controlled trial comparing clinical, by that I mean imaging, versus surgical staging for cervical cancer. And this study showed that in the group that had surgery, they found 25% of patients had para-aortic lymph nodes in this group. But of course, the complication was higher in the lymphadenectomy arms. There were 2 lymphadenectomy arms, one retroperitoneal, one extraperitoneal, and the study was stopped prematurely. Does that sound familiar? A randomized control study comparing a laparoscopic approach for surgical cancer stopped prematurely. The hazard ratio for relapse was 3.13 with surgical staging. So there's no role for surgical staging or para-aortic lymphadenectomy in cervical cancer. So I'm afraid my conclusions are this. There's no role for systematic lymphadenectomy in any gynecological oncology practice, perhaps with the exception of rare germ cell tumors. There's a role for sentinel lymph node dissection, there's a role for imaging. But systematic para-aortic lymphadenectomy just causes harm in all cancers. And moving forward, this is something that I feel will be abandoned. So I've purposely been controversial in my presentation today because I thought it would promote some discussion, and that's the end of my presentation.